Anal fissure is one of those common surgical, especially the general surgical conditions in which a patient will report to you maybe in ER or maybe in the outpatient department. Today we'll be talking in detail about the anal fissure, and before that you should know about a little bit of the anatomy of the anal canal. So let me just give a quick review about the anatomy of the anal canal. So we know that actually the rectum all the way is continue to form the anal canal, and it's being divided into upper half of the anal canal and the lower half of the anal canal, and the demarcation between the upper part of the anal canal and the lower part of the anal canal is obviously the dentate line. We actually know that there are multiple anal columns, and these anal columns and the anal folds, they end together at the dentate line, making up the anal folds. We talk about the differences between the upper half of the anal canal and the lower half of the anal canal. We also talk about, the differences and their epithelium, their nerve supply, their lymphatic drainage in the past couple of lectures. So I won't be repeating that once again, but you should have a little bit of the idea about the upper half and the lower half, and the demarcation is the dentate line. Now, there are some important sphincters, okay? So you can say the sphincters are actually the muscles, and they are actually controlling your active defecation. So actually one is the involuntary sphincter and the other is the voluntary sphincter. So we have got the internal anal sphincter and the other one is the external anal sphincter. And internal anal sphincter is more medial in location. It is very close in continuity with the mucosa of the anal canal, and just above, outside of the internal sphincter, we have the external sphincter. And there are three different parts of the anal sphincter. We know the superficial part of the anal sphincter, the deep part of the anal sphincter, and the submucosal. So if you are moving from outward to inward, then the outermost part of the external anal sphincter would be, the subcutaneous external anal sphincter. Then you have the external sphincter, which is superficial, and then you have a deep part of the external sphincter. So these sphincters are important because the internal anal sphincter is under the autonomic control. And that's a kind of an involuntary sphincter, and the parasympathetic fibers, they're coming from the sacral segments, and they are actually all the way coming to the internal sphincter, and they are controlling the act of the defecation involuntarily. Now, any kind of injury, the spinal cord injury, or the traumatic injury to the L5S1 segments, the lumbosacral and the sacral segment specifically, because the nerve root is coming from those values, and if there's an injury to these, that can lead to the fecal incontinence. Now, if we talk about the part of the external sphincter, it's a voluntary sphincter. So actually, if you are feeling the act of defecation and there is urge of defecation, and there is the involuntary internal anal sphincter behind that. But when you go to the toilet, you sit, and then you try to defecate, that's under your voluntary control, and the sphincter behind that is the external anal sphincter. I'm not going into the detail of the act of defecation, how it works, and what is the role of the parasympathetic fibers, and how the sacral segments are actually contributing to that. But still, you should know that these sphincters are very, very much important, and there are some conditions of the anal canal which are directly or indirectly targeting these sphincters. And why this is important? Because to understand the anatomy and their proper location and to find out the proper plane is very much important when you are doing the operative surgery. So anal fissure is actually the tear or the break. You can say it's a tear or a break in an anoderm, and it's extending. It's usually lying in the posterior midline, but it's extending to the dentate line. So if you could appreciate here, this is the this is a left lateral position, so the patient is actually in a left lateral position, and you can see that this is the anterior position, because we know that the part which is facing the genitalia, they are That is the anterior part. So talking about this anterior part, this is the anterior part and this is the posterior part. And you can say there's a transverse line or demarcation between the anterior and the posterior part of the anal canal. So actually it's extending from the posteriorly in the midline. It's all the way extending. It's actually the tear in the anoderm, but it is extending into the submucosa and it's extending up to the dentate line. So it's actually, you can say, a tear in the anoderm, and usually if we talk about the location, it's mostly in the posterior midline, and it extends from the anoderm into the submucosa, and then it goes inward towards it extends to the dentate line. Now, the important thing is, how the tear is being generated and how a patient is actually going to present to you, and what would be the complications. We'll be discussing this in a couple of minutes. But the most important thing is to know that repeated episodes of the diarrhea or a chronic constipation, that are actually the causative factors behind that. And most commonly not, people think that maybe it's a constipation because you're straining and you're putting a lot of pressure. And when the anal pressure is increased, the sphincters actually contract and they try to decrease the sphincter tone. And when the sphincter tone, they try to increase the sphincter tone actually. So when the sphincter tone is increased, that would be causing more of a pressure would be generated and a tear in an anoderm would be produced. So we actually classify these on the presentation. So there's acute anal fissure and there's a chronic anal fissure. So talking about the acute anal fissure, we actually know that what is the acute presentation, a little bit brief history, and the patient would be complaining about a painful defecation, and he will be giving you a very brief history. That would be acute anal fissure. And the chronic anal fissure, if the patient is repeatedly committing, or maybe the patient initially reported to you with acute anal fissure, and now after 2 or 3 months, the fissure is not, relieving, or the pain is still there, or sphincter tone is still not better or returns to the normal, then actually that is termed as a chronic anal fissure. So acute, a brief history, and the chronic, which is repeated episodes, or, after still resistant or persistent to the conservative treatment, that becomes a chronic anal fissure. And there can be associated external anal tags that would be actually showing you. But if the painful defecation persists and there's ulceration and there's itching, then you'll think about the chronic anal fissure. So there can be acute and chronic anal fissure. And if we talk about the causes of this presentation, so there are a few important causes like the acute anal fissure, and there are other causes for the chronic anal fissure. There can be association with some other diseases, but usually the act of constipation and the repeated episodes of the diarrhea, they actually increasing. There's a shearing force and a friction is also increased, and because of that, plus the anal pressure is increased so much, and there's a tightening of these sphincters, especially because they're musculature in nature. And when we talk about the muscular nature of these sphincters, they actually contract and they increase more of the anal pressure. And because of the more of the increase of the anal pressure, that would lead to the tear in an anoderm. Now, talking about the constipation, what it actually causes, a constipation can be like, a lot of bulky stool and the hard stool, okay? So if the stool is very bulky, or if the stool is little amount but very hard, you will strain, and the straining would put a lot of pressure in your anal canal, and the anal pressure would be increased, and that would evacuation of the hot stool and straining, that would cause a tear in an anoderm, or the repeated passages of the diarrhea. Now, how come the repeated passages of the diarrhea? Because you are again passing stools. They are watery, inconsistency, and because of that, sometimes the bowel habits there's a kind of constipation alternating with diarrhea, and because of that, the skin is actually again and again in contact with the stool, which is a cause of which is a kind of an irritant to the endoderm. So it also increases, makes the endoderm vulnerable to tear. Now, if we talk about the chronic anal fissures, the causes include repeated trauma, or there can be anal hypertonicity and a vascular insufficiency, because when the pressure is increased, anal pressure specifically is increased for a very, very longer time, there's a compression of the arteries, and that can lead to the vascular insufficiency. So always remember, the acute anal fissure, if lasting for more than 2 months and it's not it's not resolving to the conventional treatment or a conservative treatment you're offering, and there is a persistence to the painful defecation, then you can say the acute anal fissure is being converted to the chronic anal fissure. So the causes for the acute anal fissure is a chronic constipation and the repeated episodes of the diarrhea. And if we talk about the causes for the chronic anal fissure, remember there can be anal hypertonicity, because there would be the sphincter tone would be higher for a very, very long time, and there can be repeated trauma, and there can be vascular insufficiency, and because of these vascular insufficiencies, there can be formation of the ulcers in case of the chronic anal fissures. Now, talking about clinical features, how the patient is actually going to present to you, the first and the foremost complaint of the patient would be painful defecation. So he would be actually giving you the history that whenever I try to defecate and try to put a strain, there's a lot of pain, and because of that, I am unable to pass the stool easily. And then the patient will be giving you the history of chronic constipation or a history of repeated diarrhea. That would actually give you the indication or a hint about the cause for the development of the anal fissure. Then there can be passage of the fresh blood, because when there's a tear in the endoderm, obviously there would be bleeding, and the bleeding is different from that of a hemorrhoids, because in case of the hemorrhoids, when the patient is actually it's not mixed with the stool, but in case of the anal fissure, sometimes it's happened that it's usually mixed in the stool, but it can be after defecation there can be some specks of the blood on a toilet paper. So the hemorrhoids are usually not painful, but the anal fissure is painful. So the one differential point in your history is a painful defecation when you compare it with the hemorrhoids. Then the passage of the fresh blood. So the hematochezia is, common in both the anal fissure and the hemorrhoids, but their presentation is different. Usually in case of the hemorrhoids, when the patient defecates completely, then after the defecation there's a frank bleed, or maybe there is a frank bleed on the toilet, or there's a frank bleed on the toilet paper. But usually in case of the anal fissure, the bleeding is mixed with a stool. Now, in case of the chronic anal fissures, because of the vascular insufficiency, there can be formation of the ulcers. So the ulcers will give you a kind of a indication for the chronic anal fissure. So if you do the clinical examination or the local perianal examination, you can see the multiple anal tags and painful defecation. Then itching pruritus, because it's more of a hallmark in case of the chronic anal fissures. It's not the presentation in case of the anal fissure, but actually those anal tags which are formed as a result of the granulation or as a result of fibrosis and the process of the healing, they cause a little bit of the itching. So itching is again the indication for a chronic anal fissure. And then there can be mucus discharge, and obviously the constipation. The history of constipation or the history of repeated trauma is actually leading you towards the cause of the anal fissure. So always think about two different things when the patient is coming to you with the fresh PR bleed. Then you have to rule out the anal fissure and the hemorrhoids, and you'll be asking about the history of the constipation, you will be asking about the history of the repeated trauma, or you'll be asking about the history of the repeated diarrhea. Then the painless or painful defecation, painless defecation is in the hemorrhoids, and a painful defecation is in the anal fissure. Then you'll talk about the PR bleeding, how actually the bleed is it mixed with the stool, or it's coming after the stool. So if it's coming after the stool, it's usually of the hemorrhoids, and it's frank in a lot of quantity. And in case of the anal fissure, there's like small specks of the blood, and they are coming along with the stool. There can be anal ulcerations, there can be itching because of the fibrosis, and because of the anal tags, acting as an irritant to the anal region. The mucus discharge and history of constipation or history of diarrhea is again very, very much important. Now, talking about the differential diagnosis, again, obviously there can be Crohn's disease, there can be tuberculosis, there can be colorectal cancer, but usually the colorectal cancers, if they are if you are dealing with the old age men, then you will mostly, and having a history of colorectal cancer, then you will be suspecting a colorectal cancer. But usually the cancers are not painful, but they can be painful in some stages, but usually they're not pain. So usually the painless bleed is the differential diagnosis with the hemorrhoids and a colorectal cancer. And if a painful thing, you'll think about the anal fissure. Now, you have to think about other conditions as well when you are encountering anal ulcers, because these ulcers can be present in case of a Crohn's disease, they can be present in case of a tuberculosis, they can be present in case of the HIV and a herpes simplex virus, and some of the sexually transmitted diseases, especially lymphoma granuloma venereum. So these or syphilis and a cancroid, there can be formation of the anal ulcer. So always keep these differentials in your mind and try to rule out, because these pure bleed in anal ulcers and the chronic anal fissures, they can have some kind of association with all these diseases. So think about the chronic disease, think about the tuberculosis, think about the sexually transmitted diseases, HIV related ulcers, very, very much important, syphilis, again, sexually transmitted disease, and the cancroids and the chlamydial infections, and the lymphoma granuloma venereum. So always take a proper history and try to rule out these differentials when you're encountering a patient with a PR bleed and a chronic anal ulcers. Now, there can be some other associated differentials. There can be herpes simplex virus, cytomegalovirus. In cytomegalovirus, the ulcers are very deep and they have roughened margins, and you have to think about this. Then Kaposi sarcoma and a B-cell lymphomas. Now, another thing which I want to share with you guys at this moment is like anal fissures, anterior anal fissures. I talk about the anterior and the posterior. So the normal in case of the constipation, and in case of the repeated episodes of diarrhea, they're mostly posterior. But anterior anal fissures can be present, but they're more common in the women of a childbearing age, especially after vaginal delivery. So if you're encountering anterior anal fissures, don't think that it's unusual. It's rare though, but it's rare in male, but it's not rare in a female. So ask about the history of single vaginal delivery, because these tears are very common after a vaginal delivery. So asking about all these chronic conditions and sexually transmitted diseases and lymphomas and Kaposi sarcomas, they are really, really helpful to exclude the other conditions. And squamous cell carcinoma, I'll talk about the colorectal cancers. Now, how you are actually going to make a proper diagnosis for anal fissure, that's only the local perianal examination and a digital rectal examination. So it's actually a diagnosis of a history and your clinical examination. You don't need any type of investigation for the anal fissure. Yes, you do sometimes need investigation to rule out other conditions, the chronic inflammatory processes, and you may need to rule out the colorectal cancer. So the perianal examination and a digital rectal examination. They are actually very, very important. So what can actually you find out? In case of the anal examination, there would be swollen anal, there can be some swollen anal tags, or there can be a possible tear with a mild bleed in an anoderm. And then in case of the chronic anal fissures, there can be ulcerations, and there can be other conditions like the itching, and there can be because the chronic anal fissure, in the process of a healing, there can be multiple anal tags. Now, another important thing is when you try to do the digital rectal examination, it would be very, very painful for the patient, because when you try to insert your finger, although you lubricate the anal canal, you lubricate your finger before inserting, but that is painful because of the tight anal sphincter tone. So actually, the tight anal sphincter tone, that would be giving you the idea about the anal fissure. So in case of the anal fissure, always remember, if the digital rectal examination is painful, do not proceed for proctoscopy, or you do not proceed for more of a digital rectal examination, and you just stop where the patient feels the pain. And that is actually a kind of indication to your diagnosis that the patient is actually having the acute anal fissure. In case of the chronic anal fissures, digital rectal examination is not that painful, so you can proceed for a proctoscopy depending upon the condition of a patient, or you can proceed for an anoscopy. Now, talking about the conservative management, we have got two important treatment strategies for the fissure. So one is a conservative treatment, and other is a surgical treatment. So we reserve the surgical treatment for the chronic anal fissures. So the acute anal fissures, in case of the acute anal fissures, we do not go for the surgical treatment. We only go for the conservative treatment, because usually 2 to 3 weeks and maybe 6 weeks of a time is taken up by the patient, or taken up by the fissure, to heal spontaneously on its own. Now, talking about important conservative treatment, the patient counseling and the education of a patient is very much important, and it's a responsibility of the attending doctor to give a proper counseling session to your patient and making understand, because you have to treat the cause. You don't have to treat the presentation, but you have to treat the cause, because if you do not treat the cause of the patient, the repeated episodes of the diarrhea or chronic constipation, even if the fissure is healed temporarily for a little bit of a time, it will be again generated. So you need to counsel your patient. So talking about the conservative treatment, first and the foremost important thing is a normalization of the bowel habits. So the question is this, at how you are actually normalizing your bowel habits, or the bowel habits of the patient. If there's a chronic constipation, then you have to address the constipation. If there's a repeated diarrhea, then you have to address the diarrhea. But mostly in a clinical practice, the cause behind the fissure is a chronic constipation. So in case of the chronic constipation, there are a few devices you have to give to your patient. One of these is like quantity of a water should be increased. Like, at least if we talk about the normal daily minimal requirement of the water, so 8 glasses of the water are sufficient in a day. But in case of the patients who have the chronic constipation, and you are thinking about a conservative treatment of the acute anal fissure, then you have to increase the intake of the water from 10 to 12 glasses per day. And you need to counsel them that you have to increase your fibrous diet, because eat as much as salads and fresh vegetables and fruits and a lot of juices and fluids in any form. If you take a clean water, or you want to take it with a green tea, or you want to take it with the juices. So that's how you are actually normalizing the bowel habits. And if it's a diarrhea, then you have to anti-diarrheal medications should be started immediately. But usually, if you are thinking about a constipation, then you have to the first most important thing is like increase the amount of water, 10 to 12 glasses of water per day, and then you have to add high fibrous diet to your patient, which includes use of the salads and use of the fresh green vegetables and fibrous fruits like oranges. And then you have to add some laxatives as well, like normally which we're using is lactulose. It's coming in a lot of formulations like Differential and Lilac and Acromafen. So these actually they increases the gut motility and their laxatives, and that's how. So you're actually addressing two things. One is the hard stool and the other is the bowel habit. So hard stool, you make the hard stool soft by the help of increasing the water content and increasing the plenty of taking up plenty of fluids in the form of the water or any other clear fluids or juices. And you are also asking your patient, advising your patient to use fibrous diet. So the fibers are also making the hard stool soft. And the other thing is a prokinetic activity of the bowel, and you add some kind of laxatives for that. The second thing, I already talked about the stool softeners, the adequate water intake, and the warm baths. Why this is important? Because you need to counsel your patient. You have to tell him that he needs to sit in a lukewarm water, saline water, or you add a little bit of the pythene and sit in a tub or a bath. That's for like 10 to 15 minutes, and this act should be repeated twice or thrice daily, and it's very helpful if you continue for 2 weeks. So usually the spontaneous healing of a fissure that actually takes place usually within 6 weeks, but if it's prolonged for 6 weeks, then that would be converted into a chronic anal fissure, and then you have to go for the surgical treatment. Now, another important thing you need to tell your patient is the application of some local anesthetic agents, and one of them is a lignocaine. So lignocaine is also used in the treatment of the anal fissure. So the first thing is like you have to make the stool soft, and for that you need to add laxatives. Then for that, you need to increase the water intake of a patient, and normalization of the bowel habits is very, very much important. And then tell your patient, because it's a tear in an anoderm, and you want to heal the anoderm, and for that, warm, saline, lukewarm sitz bath of the patient is very, very much important. Then anesthetic agents, you can treat it with a topical anesthetic agents, or you can treat your patient with the other agents like tablet forms formulation. Because if a patient is complaining of a pain, then you have to administer oral formulations as well. Now, some kind of a pharmacological agents are also used. There are some agents which are the nitric oxide, or you can say they are actually the formulation of the nitric oxide. So we know that the glyceride trinitrates, they are actually working. They are the vasodilators. So when they dilate the vessel, they increases the blood flow to that particular area, and they help in the healing of that particular area. So the vasodilators like the glycerides, especially the triglyceride nitrates, they are used, and there are topical applications available in the form of 0.2% GTN, which is glyceride trinitrate paste, and this paste is applied twice or thrice daily, depending upon the condition of the patient. Now, they actually not only vasodilate, but they actually also relieve the spasm of the sphincter, and they decreases the sphincter tone, because we know that when the sphincters are tight and their pressure is increased, then obviously that will tighten the sphincter tone. So actually you want to decrease the sphincter tone, and you want to relax the sphincters, and for that these dilators are also used. Then nitric oxide donors told you the most important a common formulation is 0.2% of the GTN paste, which is glyceride trinitrate. Then the other can be used as a diltiazem. And a dialchiasm is also vasodilator, but it's a calcium channel blocker, and you use it in a 2% of the formulation, and it's used twice daily. But if we talk about the nitric oxide donors, and we talk about especially 0.2% GT and paste, you need to counsel the patient about the headaches, because we know that these nitrates, they are very much known for their side effect of headache. So if they are topically applied or they are taken orally, they have a side effect of the headache, and then you have to tell your patient he may report these symptoms. Its use is limited because of the worsening headaches, because some of the patients who are, the chronic patients of migraine, they actually experience very worse headaches. So because of that, use is limited. Diltiazem is, again, I told you it's a calcium channel blocker, but it's a non-pyridine, hydropyridine calcium channel blocker, but its mechanism still remains the same. It's dilate the vascular, releases the sphincter, spasm, and decreases the tone. And because of that, but if you talk about the frequency of the headache, it's very, very much less with the diltiazem as compared to 0.2% GT and paste. So if the patient is using triglyceride trinitrates, then it's 2 to 3 times per day, and diltiazem is applied for twice daily. Then there's some other formulation as well, which is the tronulin gel. So the tronulin gel also releases the spasm, decreases the vascular insufficiency, and it has a little bit of the anesthetizing agent effect as well. So think about if we talk about a regimen for the conservative treatment of the acute anal fissure, then you have to combine the stool softeners like laxatives, and then you have to combine them with the anesthetic agents, the topical anesthetic agents, and you have to combine with the dilators and nitric oxide and glyceride trinitrates and a diltiazem and a topical formulations. And then you have to counsel the patient about use of the water, a lot of water, or the juices, or take plenty of fluids in any formulation, or combining high fiber diet and sitz bath. They're very, very much important in the process of healing. Now, anal dilators, they were also used in the previous couple of centuries, but now their use is also limited. There's another important agent which is being used, that is the injection of the botulinum toxin, which is Botox, and it's if we talk about the quantity, it's varying from 10 to 100 units, and they are injected in the perianal region, and they again, because it's botulinum toxin, is a neuromuscular blockade, so actually it blocks and it releases the spasm of the muscle or sphincter. So these are the things which can be used in a case of the conservative treatment. Now we have got some other operative measures as well. So if we talk about the operative measures, they are basically used in case of those conditions which are persistent. And if you have given a treatment, a conservative treatment of anal fissure for 6 weeks, and it's not resolving, or if a painful defecation is persisting and a sphincter tone is tight, then you have to go for the operative measures. And if we talk about the operative measurement, there is lateral internal sphincterotomy, and there are different techniques for that. There can be open lateral internal sphincterotomy, and there can be closed internal sphincterotomy. And I would be telling you the differences between the closed technique and the open technique in a while, but you should have a little bit of the idea. So let's just have a look at the picture. So this is actually the anal verge, okay, and you can see these are the anal columns, and they are usually above the dentate line, and they actually meet in the midline to the dentate line, and you can see that this is a fissure. So the fissure is present in a posterior midline. And what you do in a sphincterotomy is like you have to divide the sphincter. Now, which sphincter is needed to be divided is obviously the internal anal sphincter. We know that it's more located in a It's more related to the submucosal surface of the anal canal, and the internal sphincter is being divided in case of the sphincterotomy. And there are two important techniques for that. But in case of the chronic anal fissures, which are persistent for a very time, and there are ulcerations, and you need to excise with the anal tags, and you need to excise the whole of the area, and then you have to do the whole of the excision, then obviously the advancement of flaps can be used in those cases. So we'll be talking in detail about that. But right now, you can see that there is a posterior anal fissure which is present in the midline and is extending all the way towards the dentate line. So what you need to do is you need to do the lateral internal sphincterotomy. Now, why this is called as a lateral internal sphincterotomy? Okay, why this is important? Because it is actually the fissure which is present in the posterior midline. So you have to divide the internal anal sphincter, either right lateral position or a left lateral position. Maybe it's here or here. You need to divide it either on the right, but it should be away from the fissure. It should not be including or incorporating the fissure. So that's actually the basic rule when you're performing a lateral internal sphincterotomy. So the only thing, if you're doing a closed technique or the open technique, actually what you have to do is like you have to find the intersphincteric groove. So actually the internal sphincteric groove is a plane, or you can say it's a groove which is present between the internal anal sphincter and external anal sphincter. So you have to do the dissection between the submucosal plane and the intersphincteric groove. So let's have the look for the other diagram. So this is actually, this is the anoscope. You can see the doctor is operating, and you can see a fissure in the midline, in the posterior midline. Okay, but the question arises, what position you need to make for your patient. You can do it in a lithotomy position, or you can do it in a prone jackknife position. So it entirely depends upon you in a position. If you are focusing more on the anterior anal fissure, then you will, a lithotomy position would be best. And if you are dealing with a posterior anal fissure, then prone jackknife position would be more helpful for you. So what you have to do is like you have to follow the open technique and a closed technique. So let me tell you what is the difference between an open internal anal sphincterotomy and a closed technique. So actually, in a closed technique, what you do, there's an anal fissure which is present in the midline. You go either on the right lateral position or you go to the left lateral position. And then you, in case of the closed sphincterotomy, you palpate the internal anal sphincter with the tip of your finger. And what you do, you take 11 blade scalpel, and if let's suppose this is a scalpel and this is the tip of the scalpel, then you have to introduce the tip of the scalpel, 11 number blade, and you have to insert it in the intersphincteric groove. That's between the internal anal sphincter and between the external anal sphincter. And then what you have to do is you have to rotate it towards the internal anal sphincter. Let's suppose this is the internal anal sphincter, and this is the external anal sphincter. Okay, what you have to do is like you have to insert the tip of the scalpel in between these sphincters, which is the intersphincteric groove, and you keep this pointed edge in the middle, and then you have to rotate the scalpel, and then you have to cut towards the internal anal sphincter, and by the help of your other hand, you palpate the fibers of the internal anal sphincter. And when you do a deep dissection and you give a nick in that, you will have a feeling of giveaway, and that would be telling you that internal anal sphincterotomy is being done. This is a closed technique in which you don't actually take artery forceps and you try to make an intersphincteric plane or a submucosal plane visible to you. So let's have the more focused about open technique. So what you do we talk initially we talk about the closed technique, and now we're talking about the open technique. So what do you do in an open technique? The principle still remains the same. Make a lithotomy position or a prone jackknife position, depending upon the anterior or posterior location of the anal fissure. And then what you have to do is you have to locate, use the anoscope, insert the anoscope, and just locate the fissure, and go either on the right side or left side of the fissure, and then start giving the incision in the intersphincteric groove. After making a little bit of an incision in the intersphincteric groove, you insert the artery forceps, and you do the dissection in the submucosal plane, and you do in a submucosal and intersphincteric plane. And when you actually visualize the fibers of the internal anal sphincter, you divide the distal end, you leave the proximal end, and you actually divide it in the middle, and you cut the distal end of the internal sphincter. It's the open technique. Why it's called as open technique? Because you are actually seeing the division of these internal fibers by your own eye, because you are just gaining entering. What are you doing? You give incision in the intersphincteric groove, and then you get entry into that. You enter the artery forceps. You do the dissection in the intersphincteric plane, and you do the dissection in the submucosal plane, and you divide the fibers, the distal fibers of the internal anal sphincter. So that's the reason, because you're dividing them after visualizing the fibers. So this is called as an open technique. But in closed technique, you were not visualizing the fibers actually, but you were going blunt, because you just inserted the tip of the scalpel, 11 number blade scalpel, and you inserted the tip like that, and then you rotated it, and you keep the finger of your left hand on the other side, and you can feel the proximal fibers of the internal sphincter with this hand, and then if you try to cut it towards the proximal sphincter, or you can say you go towards the dentate line, and then a feeling of giveaway would be felt on this finger. So, okay, talking about the closed technique. So maybe this picture is going to help you. You can see this is the lower half of the anal canal, and this is the upper half of the anal canal. This is actually the fissure side. So what you do is you are going, because it's a left lateral position, so you're actually going lateral, and this is the external, this is the internal anal sphincter, and this is the external anal sphincter, and it's the intersphincteric groove, the area. You can palpate it. It's a kind of a depression between the internal and external anal sphincter, and you can palpate it. So what you do is, after the palpation of the intersphincteric groove, you insert the scalpel, and you try cutting this towards this, and then a feeling. Okay, so this is actually the internal sphincter. You're going all the way from here, and a distal end, 2/3 of the distal end of the internal sphincter is being cut, and only 1/3 of the sphincter is left behind. Okay, so what you do is distal part is separated and the proximal part is separated. So the division of these actually will reduce the spasm. A little bit of pressure would be released, and the sphincter tone would be a little bit decreased as compared to the previous tone. So in closed technique, you're not dividing the fibers by visualizing them, but you're going bluntly, and you're just finding out the intersphincteric groove. You're inserting a scalpel and keeping the tip of the scalpel here, and you're dividing the distal fibers from these are the proximal fibers and the distal fibers, and you divide the 2/3, and 1/3 of the internal fibers are left in place. So this is actually the closed technique. So see, you're actually going in this intersphincteric in a submucosal plane, and you go all the way here, and then you rotate it. Okay, so you actually you went this way, but you have to rotate it towards the proximal end. And so this was actually the scalpel end, and you need to rotate this towards this so that it can be divided, and leave the proximal end and divide the distal end. Okay, so here the scalpel was inserted all the way, and you rotate it, and the 2/3 of this margin of the distal internal anal sphincter was being divided. So that's how the lateral internal sphincterotomy by closed technique is done. Okay, now talking about, I hope you are familiar with the open technique and a closed technique. The only difference is the principles remain the same, but the only difference is the visualization. If you're directly visualizing the internal anal sphincter and you are doing it under direct vision, the division is under direct vision. This is open technique because you actually split the whole of the mucosa, and you went all the way and you created a dissection plane. And if you do not create a dissection plane, you just enter the intersphincteric groove and you will blindly and rotate the scalpel, and if you have a feeling of giveaway by your left finger, then that is called as the closed technique. Now, there can be some complications of the lateral internal anal sphincterotomy. That can be hemorrhage, that can be hematoma formation, there can be a little bit of a bruising, there can be perianal abscess, and there can be fistula formation. Now, it depends. You don't have to be sharp. You have to be very controlled, and you have to be, because 1/3 of anal sphincter is left, so it's sufficient for the anal. So, but if you do a lot of cutting, then the patient can have the urinary incontinence as well. So, first post-operative day is very, very much important because you keep on monitoring the incontinence. And it's important that your patient passes stool and there is no your fecal incontinence. Now, there can be hemorrhage if you do a lot of dissection, hematoma formation, bruising, perianal abscess. But in case of this, lateral internal sphincterotomy, the incision is left open. You do not close it. You just do the anal packing, and the pack is removed in the evening. The fine and absolute hemostasis is the responsibility of the operating surgeon, and then you have to look for the anal incontinence. Now, if the chronic anal fissure is persistent for a very, very long time, then what do you have to do? You have to excise the whole of the anal skin, right? And the whole of the anal verge, enclosing or incorporating the anal tags and the ulcer. And obviously that defect would be created, and that defect would be, if you use the advancement flaps, the defect can be used. Now, if we use a different, the plastic surgeons, they have different techniques for the flap advancement. And if you should know a difference between a flap and a graft. So the graft is only it can be a partial thickness graft or full thickness fragment consisting of dermis and epidermis. And a flap and a graft doesn't have its own blood supply. And a flap is the area of the skin composing of epidermis and dermis and some of the subcutaneous fat in a tissue, so that it will have its own blood supply. So these flaps actually, there are multiple ways of taking the flaps. There can be VY flaps, there can be rhomboid flaps, which are the diamond-shaped flaps, and they can be used depending upon the area which you have actually used. So if we talk about the anal repair, so in case of the anal repair, after the excision of the chronic ulcerations and the chronic anal fissures and anal tags, defect area is created. So actually you give a VY plasty is being done. A V-shaped incision is initially given, which is extended into a Y shape, and you try to pull it off and you try to close the defect. That is a VY flap. And there can be some other, so you can see that was the area. And after the removal of the chronic anal ulcers and chronic anal fissures were being removed, This flap, V flap, was converted into a Y flap, and it was being stretched to the perianal region along with its subcutaneous fat and a tissue, because it would be having its on, and then it blood supply, and then it would be sutured. There's some other flaps which can be used. So let's suppose that was the anal area, and maybe the alteration was huge, and it was involving the whole of the anal orifice. So how are you going to do that, or how are you going to do the anal repair? So you give actually a diamond shape incision. It's a rhomboid flap, which was also used in the case of the pilonidal sinus. It's a this was the exertion area, and you extend it all the way here, and this is actually the flap area. So this was the excision area, and this was the flap area. So after the excision, you stretch one corner of this flap to the excision area, and you try to cover it. So after the excision, what you do is you bring this area all the way here, and you do put it. Now, in case of the plastic, what is important is your measurements, and it's very, you can do multiple Z plasties and VY plasties, and their own point flaps. They're being used for different kinds of perianal defects which are being generated after the excision, and it's difficult to understand by a diagrammatic representation, but still it will give you the idea that excision was made in a diamond shape area, and then this was the shape of the incision that was being given. And after the excision of this area, this flap was flipped 180 degree, and this was rotated all the way here, and it was being sutured. That is also a surgical treatment that can be used. So in today's topic, we discuss about the anal fissure. We discuss about the different causes for the generation of anal fissure, and we talk about that it's actually most commonly the posterior midline fissures are common, but in case of the woman of a childbearing age and after single vaginal delivery, they can report with the anterior anal fissure. And if we talk about the symptoms of painful defecation, PR bleed, and blood mixed with the stool, there can be itching, there can be chronic irritation, there can be ulcerations in case of the chronic anal fissure. So if there is a short brief history, there's acute anal fissure, and if it's persisting for more than 2 months, that is called as a chronic anal fissure. Now there's a difference between the treatment strategies. We manage the acute anal fissure with a conservative treatment, and it's healed effectively in 6 weeks. And if the fissure is not healed for 6 weeks and it is entered into a chronic anal fissure category, then you have to offer them a surgical operation. And the most common techniques, initially anal dilators were used, but they are no more recommended. Why? Because when you try to insert the anal dilator, there's a risk that you're going blindly, and you can injure the external and the internal anal sphincter, and the patient will report to you with anal incontinence. So better is like you do the lateral internal sphincterotomy, and there are two techniques which are used: open internal anal sphincterotomy and closed in open technique. You actually give a little bit of a small nick in the intersphincteric groove between the external and the internal anal sphincter, and then you do take arteforceps, do the dissection between the intersphincteric plane and a submucosal plane, and divide the distal fibers of the internal sphincter under direct vision. That's the open technique. And in closed technique, you don't actually divide the distal internal fibers under direct vision. You just go blindly, and the tip of the scalpel is inserted in the intersphincteric groove. You rotate it toward the proximal side, and then you divide the distal fibers 2/3 and 1/3, and the feeling will give away, and a palpation of the proximal fibers of the internal sphincter with the left hand will give you a feeling of giveaway. And there are some complications. There can be some complications of the disease, which includes of the operative procedure. That can be hemorrhage. There can be hematoma, perianal abscess, and you need to be very, very vigilant in all these. And the most important complication can be anal incontinence. If there is too much of the cutting of the internal sphincter fibers, then the patient can actually report to you with the anal incontinence. So when you're doing, either if you're following the open technique or a closed technique, 1/3, 2/3 ratio should be kept in your mind. So that's all for today. Thank you for watching sqadia.com with Dr. Sana Khan, General Surgery course.